Simmer down.
You guys don't look as tired as I thought you would.
We are.
I mean, normally, like, this time of year, it's just like, oh. And then when you get to June, like June, July, and August is fun. You splint and you do all that crud in there. It's like more fun. And it's just like, this semester is hard.
We had Pete's Day yesterday, though. That was fun.
You had what?
We had little kids come in and we
Cool.
practiced on them. That was exciting.
Oh, goodness. Rachel, oh gosh. Rachel had some interesting things happen. It was just like, oh my. Yeah. There was some interesting people she had to work with. Like, they pay these people to come in and you work on them. Like, yeah.
Oh,
It's just like,
the
what
surrogate.
job do you got? I'm like, oh my gosh. Some of the things that she was doing to these people, I'm like, they pay people to do this? I'm like, what the heck? I was like, what is that all about? Like, okay. Yeah, so anyway, and once rotations come, it's so much fun. Yeah. And Rachel said, because it was a lot. She was the youngest in her class. Rachel was. She graduated college, and she's young for her age anyway. And she's far from us, and so there was a lot of. I came down a lot, and stayed with her, which twist my arm, come to Florida. I mean, really, And so, and she barely went to the beach. She barely did anything. Here she is, and then when she gets to rotations, she's like, I would have done all of that all over again for doing what I'm doing now. So there's light at the end of the tunnel, really, and it's all worth it once you get in rotations because it's so exciting, and you're delivering babies, and you're intubating people, and you're saving their life. It's like insane, So, and all the hard work that you put in. But based on what I see coming, you guys are going to be able to name your price. You'll never have to worry about unemployment. And it's only going to get better for you guys. So you've chosen wisely. All right. Note number 2. All right. We have 2 more notes, and then some wrap-up stuff, and it's Friday out the door. Okay.
Yeah.
All right. All right. Here we go. Testicular pain. He got kicked by a horse. Oh. I know. I chose this one on purpose. I want you to know that. Okay. Yes, and coders do laugh very hardly at the things they read. Oh, some of it is so funny. Okay. He states he was feeding a horse, and a horse was scared, and he kicked him in the testicular area. The severity, I love this part. The severity, it's 13 out of 10. I was like, print that note right up. We're going to use that one. That was a good one. All right? Associated signs and symptoms. He's afraid to pee. Okay, that's enough. All right, here we go. Okay, so what do we have here? Let's go back to our little note. Okay, I have severity, 13 out of 10. I have location, I have duration, I have context. What's the context? He was feeding the horse. Associated signs and symptoms. He's afraid to pee. Do we have 4? We can stop right there.
Yeah.
Because all we need is 4, right? There's 4. All we need is 4. We can stop. We can laugh about the other stuff, but we can stop, okay? Counting. All right? So let's go back. Review of systems. Whoops, wrong note. Review of systems. Here it is. And he is checking off things. You see how he's backslashing on things?
Mm-hmm.
All systems negative except as marked. You see that little caveat right there? They'll do that in the ER. Basically, that right there is a caveat. All systems negative except as marked. And you'll see that in people's notes when they do the verbiage. A 10-point review of systems negative except as marked. All systems negative except as marked. They do all that. Basically, that's a complete review of systems. We don't even need to start counting. That right there is a caveat. Okay? But you see these backslashes, he's saying everything's negative. Although there should be something pertinent positive. That's why they came in, right? Testicular pain. Okay, so let's go back to the audit tool. And there you go. Review of systems complete. So we've got 4 and we've got to complete. Now we need all 3, so let's see what we've got for the family and all that. Past history. Obesity, chronic, and what does that say? Chronic abdominal pain on the left side. He's had surgeries. He's on some meds. He's a pack per day smoker. He's an occasional alcohol, and family history is non-contributory. Okay, so here we go. Let's go back. I have 2 because I have past history and social history, right?
Wait,
So
family history. Contributory.
Yeah, that was not contributory. So, but he smokes. So that right there. So that's 2 or 3. Comprehensive. Would you say we have a comprehensive history here? Yes. On the side, write comprehensive history. Good. You guys are getting it. This is awesome. All right, here we go. Okay, so here we go. Here's our little exam. And notice this T-sheet looks different than the other T-sheet we had. There's a lot of different T-sheets in the ER, and they're usually pulled according to what the problem is. Okay, and they usually have, if it's like a laceration one, you'll have an area for a laceration. You know, although everything's going to Epic now and stuff like that, but this is the way it was done. All right. Let's see, vitals were reviewed. It's got some abdominal business, so that would be like GI. Of course, everything's GU. Here we go, everything's GU. We got respiratory, cardiovascular, extremities, which would be edema, neuro, skin. I see nothing is 4 by 4, so we have to count and see whether we've got 8. We got 1, 2, and we got psych in there, neuro and psych. I know they put them together, but in this sheet they're double. They're separated out. So his mood is fine. So psych, we're going to give him psych. That's 1, 2, 3. We're going to give him range of motion. 4, that's musculoskeletal. Edema, lymph. 5, cardiovascular. 6, respiratory. 7, and then we've got GU. 8. Would you agree we have 8?
Yeah.
Okay. All right. So here we go. Let's put that on. We have 8. 8 or more systems. Here they are. We had vitals, you checked the vitals, cardiovascular, GI, GU, musculo, neuro, psych, and lymph. We have 8. Okay, we don't even need to worry about the regular or the 4 by 4. We have 8. Okay, so let's go back and let's see what was done. Okay, here we go. Labs. He did a urinalysis. It's normal. He did a testicular scan. He has a small hydrocele. So he did a testicular scan. And he's giving him ibuprofen PRN. He didn't even prescribe a med. I was like, 13 out of 10 and you're not giving him a med? I was like, okay here.
That's cool.
Some things are so funny. Ankle pain and we're giving Norco, and testicular 13 out of 10 getting kicked by a horse and just go take an aspirin and get out the door. I was like, okay, whatever. I wasn't there, so whatever. So ibuprofen PRN, okay? All right, right testicular pain. He couldn't find anything wrong with the guy except a hydrocele, but there's no, anything more serious because of the kick. So there we go. Okay, so let's go back and put that in there. All right, so is it a new problem to the examiner? Yes, it is. Okay, so I'm going to put 1 times 3 is 3, because he didn't send him anywhere else for any more scans or anything like that. So that's 3. So come down here and put 3 here. Okay, let's go to box B, which is here. All right. I know he gave over-the-counter drugs. There it is. He didn't give him any prescriptions. Okay, but let's see if you agree with me here. And there's some gray area and some coding, and this is where some of this kind of stuff would be. Okay, but there's a couple things about coding. Okay, I want to try to code as subjectively as it can be sometimes, and it is subjective sometimes. Okay, like this is going to be a little bit subjective, what I'm going to talk to you about now. As subjective as it can be, I need to be as consistent as I can be in that subjectivity. Okay, so that means if you hand me 10 charts like this over a 2-year period, I'm pretty much coding them all the same way. Do you understand? I got to have it set in my mind that I've got some really good ideas of how I'm going to do this and what makes sense to me, so that I'm like going down the road nice and straight. if I'm coding it one way one day and another way another day, I'm all over the place. I need to have some things in my mind, you know? And it needs to make sense, okay? And I need to be able to defend it in court. And if I can say, looking and saying my reasoning, there are times when I code a chart and I'm like, and then I think, okay, well, what would I say? What would I say to defend myself here? Well, I was taking this into consideration and I was thinking about that and I saw this and this looked like this, and then I say, yeah, that makes perfect sense, okay? Now, that doesn't mean another coder might not have seen it a little differently, okay? But like I said, I need to be as consistent as I can be, and I need to have really good rules in place in my mind so that and sort of code things pretty much the same way, okay? And that's what I'm trying to caution you now. And this is what I'm going to say about this one. This presenting problem. I mean, getting kicked by a horse. I mean, come on, okay? That could be potentially pretty serious, okay? I'm not a guy, but that could be potentially pretty serious. I had a doctor put critical care on something like this once, okay? So I mean, I'm going to give the benefit of the doubt here, and I'm going to say this is an undiagnosed new problem with uncertain prognosis at the time of presentation, because it's presenting problem. At the time they came in, he really didn't know, and it could have potentially been an issue. It turned out not to be. After he did the scan and everything, it turned out not to. But what does the column say? Presenting problem. It doesn't say at the end of it all. It says presenting problem. It was an undiagnosed new problem. And in my mind, that's a whole lot different than an ankle sprain. Doesn't it feel like that to you? Okay? All right? So I'm going to say moderate. Now, you might have another coder come here and say, no, that's definitely a stretch, Jane. I'm not saying, but to me, that feels like this. Okay? He did a scan. I know he prescribed over-the-counter meds, and that bothers me. But yet, when the time of presentation, at 13 out of 10, he's telling the doc he's at 13 out of 10. Now, if I said that to people, you could see where you could agree with me. I mean, you might not totally agree with me, and you might say, I'm really stretching it. But you can see where I can come up with this, can't you? Okay. Okay, so I'm going to say moderate there. And therein lies my gray area. Okay? Now, does anybody want to debate me on this? Or you're more than welcome. We can talk about this. Or does anybody see something different? I think every guy in here will probably agree with that, you know? So, and I'm going to give you the benefit on that one. Okay, so I'm going to say it's moderate. Okay, so here we're over here to box C. Okay, they did a lab. Remember the urinalysis? Circle 1. They did a CT scan, a testicular scan. That's in the radiology section. That's 2. I'm going to give that a total of 2 points. Okay? I don't think he mentioned that he looked at the scan himself. I don't think there was anything mentioned there, so I'm not going to give credit for that. All right, so we're going to come down here, and box C is 2. So we have 3, 3, 2. All we need is 2 of 3, because here it says it. It's moderate MDM. Would you agree? Mm-hmm. Okay. What am I doing? Okay, so here we go. Ready? Oh, I know where I need to go. Right here. There it is. Ready? Okay, so if it's a new patient, what do we need for a new patient? 3 of 3. Okay, and right now we have a comprehensive history. So we have comprehensive history. We have a deep, what did we have? A comprehensive exam?
Yes.
Okay, a comprehensive exam. Okay, so at this point it's either a 4 or 5. Let's see what it is. And we have moderate medical decision making. It's a 4. Okay? Would you agree that it sounds like a 4? 5, high is high. High is, you know, so this sounds like a, is this more than an ankle sprain? Yeah. Is this not as bad as chest pain, potentially MI? Yeah. Do you see where it falls? You see how it makes sense? And you see, we can make sense of this and you can sleep well at night because you're like right on track, okay? Okay, so let's say 2 out of 3. Okay, so we have a comprehensive history, a comprehensive exam, and moderate medical decision making. Now, technically, we have a 5, don't we? But remember, what's the overarching criteria? What was the overarching criteria? Medical decision making. And since it's a moderate, I'm not going to give it a 99215. I'm not. I mean, you could have another coder say, well, it says 9, but yet Medicare says the overarching criteria is medical necessity. And it really doesn't feel like a 5 to me. I don't care if we only need 2 of 3. It doesn't feel like a 5. Okay? It feels like a 4. I feel good about that. Are you good? Okay, now the last note is not a template. We're going to pick the pieces out. And I do not have the cheat sheet here. I don't have my cheat sheet on this one. So we're going to do this blind, okay? So it's up to you, okay? So we're going to like talk it out. Everybody's going to shout out things, and we're going to count them up. Okay, here it is. I'll tell you right now that this is looks like a pre-op visit. And they're for hammer toes. Okay? So it's a pre-op for hammer toes. We're doing a hammer toe surgery. All right? So here we go. HPI, here it is. The 78-year-old female who has had multiple foot surgeries in the past, she's been seen by Dr. D in the clinic and found out hammer toes on both her right feet, 5th digit, and left third of her lower extremities. This has been ongoing difficulty with the patient, including her ambulation, and it is determined that surgery was going to be needed to correct this at this time. Currently, the patient is in the preoperative area with no complaints at this time. Okay? So basically, what do we have? We have location, right? Duration. I think she has severity, or like, oh no, associated signs and symptoms. She has difficulty ambulating. What you say? Associated signs and symptoms? What else? We need one more. Do we have anything? We have 3. What'd you say? Would you say we have 3? Okay, then we have 3. Okay, then let's go back and let's put that on there. It's going to have to be right there, 1 to 3. Right? Right there, that takes us out of the comprehensive, so but we're going to do it anyway. Past medical history, she has hypertension, dyslipidemia, type 2 diabetes, and GERD. She's had a squamous cell carcinoma in the past and osteoporosis.
Can you do it based on 3 chronic conditions or not because you're not treating them?
Well, let's go to here. He is.
Okay.
At the end, he is, but you didn't know that then.
Okay.
Okay, but we'll go back. Okay, but we're just trying to pick things out for now. Okay, but very good call, very good catch, because at the end he does. Past surgical, she had a bladder suspension, blah, blah, blah. Social history, she does not smoke. Okay, family history is non-contributory. Okay, so let's go, let's do the review of systems while we're here. A 14-point review of system was negative except for what was stated in history. Okay, so we can finish the history right now. Here we go. Ready? Okay, so we've got this for the review of system, the HPI, at least at this point we do. Okay? Although he really didn't mention it in the HPI. He really should have. So I don't think I'm going to give it to him. I'm not going to give it to him at the end. I disagree with myself. I think we're gonna because he should have mentioned it in the HPI. I can't take from the HPI. I can borrow from review of systems the HPI. I can do that. I can borrow there, but I'm not going to borrow from the assessment and plan to give to the HPI. No, he should have mentioned it there. He did not. Okay. All right. So anyway, review of systems. It's a complete because he said it's a 14-point review of system. That's complete. And then past history. They have that, and social history, that, and so that's comprehensive there. So we've got, we have brief, complete, what do we have? We have expanded problem-focused history. Because remember, we need 3, so we've got to go to the left, and there it is. And there's the verbiage on that. If you ever forget that, it's right there. Okay, so it's an expanded problem-focused history. Okay, let's go to the exam. Here's your exam. We've got vitals. Check that off. We've got ear. We have eyes. Oh, we have lymph. We have lymphadenopathy. We have a cardiac. Regular rate, rhythm, normal rate, no murmurs, rubs, or gallops. Oh, I would think that's 4 things right there. Wouldn't you think that's 4 things? Okay, respiratory, clear to auscultation. Sorry, that's only 1. Okay, abdominal and soft and non-tone bowel sounds. There you got GI. Okay, extremities. See how they're mixing body areas and body systems? Oh, I hate that. But whatever. Really, that's not good, but that's not good in a note. But anyway, there's no clubbing, cyanosis, or edema, so of course you got the limb. And she's got a hammer toe, so you got musculoskeletal. Okay, in this instance, do we have 4x4? No, it's gone, that's gone, so just like boom. Okay, so now it's anywhere between the 2 to 7 to the 8+. Do we have 8+? No. So we got 2 to 7. So that was by default. There, that's easy enough. Okay? So what kind of exam do we have? See, you guys are awesome. You guys are getting it. It's awesome. We have an expanded problem-focused exam. So we have an expanded problem-focused history, an expanded problem-focused exam. Let's go to the medical decision-making, and we are done. Look at this. Okay, lab data. Look, she had labs. Doesn't matter how many. There's labs. Chest X-ray and an EKG. In box C, you remember box C? Let's go to box C. Here's box C. We have labs, we have EKG, and we have radiology. That's 3. 3. Box C is easy. It's 3 points. So come down here in box C and put 3. All right? Okay. She has hammer toes. I'm going to bypass box A at this point. Okay? Because we're gonna deal with box B, because we already have moderate in box C. So I'm gonna see what we can get in box B, and let's be done with it. Okay? All right, so here we go. Would you say that this is a minor surgery with identified risk factors? Would you say that? I would say that, because she's 78 years old and she's got some chronic issues. In my mind, that sounds like that. Whereas it's not major surgery. And then they have minor surgery, right here, is minor surgery with no identified risk factors. I think she does have some identified risk factors. Hypertension, you know, she has, you know, all those chronic conditions. She's 78, for heaven's sakes. I mean, you know, I think it's a moderate. Would you agree, or would you not agree? I think if she was younger and more healthy, I wouldn't be so adamant about this. But I think it makes some sense. It's minor surgery, yes, not elective major surgery, you know, in her stomach or something like that. So I think it's minor surgery, but I do think she has some identified risk factors, or else she wouldn't be going to this pre-op visit with this guy managing this. What do you think? And you can even say this. Think about this. 1 or more chronic conditions. She's had these hammer toes for what? 2.5 years? Is that what it said? 2.5 years? And it's got some mild exacerbation to it. Because didn't he say it's now she needs to have this treated? Okay, so I could even make that case right there. So it's moderate. I feel good about moderate. Do you feel good? Okay, let's go back. So here we go. Wow. Okay, so if it's a new patient, we need 3 of 3. We had an expanded problem-focused history, an expanded problem-focused exam, and a moderate medical decision-making. What do we have? 99202. That's a new patient, so you need 3 of 3. Okay? But an established patient, what does it sound like? An expanded problem-focused history, expanded problem-focused exam, and moderate medical decision-making. It's a 99213. And it feels like a 3 to me. It feels like a 3. Right? Okay? Now, are there any questions about leveling? It's not that difficult once you like slow down. Now, and eventually you'll be able to get this in your head, but I'll tell you right now, memorize this in your head, or get your little cheat sheet out. Get that in your head and everything else falls. You get that in your head and you say to yourself, okay, how much exam do I have? Boom, you're done. You don't even need to worry about anything else unless it's a new patient. You need 3 of 3 at that point. But get this and grab one of the other ones for an established patient and you're done. But get this. Get this in your head. Get that in your head. Okay? And keep your cheat sheet with you, like your little card in your thing. Okay, now here, let me finish out. We've got a few more things to cover and we're done. Now that you know coding, I'm going to give you 2 real-world examples and you tell me if they were coded correctly or not. Okay? A relatively healthy individual, 50 years old, no chronic illnesses at all, except obstructive sleep apnea. Okay? He has obstructive sleep apnea and he's on a CPAP. Okay? The doctor has to monitor him every so often. Okay? So On the CPAP, he's doing great. No exacerbation of anything. He's doing better. You know, the tests show that and all that business. Okay. And it's an established patient, so we're going to do a 992-1 something. A 99215. What? Sleep apnea? What kind of body areas were even talked about besides that? And is there any exacerbation? Now that you've seen the medical decision-making part, the A, B, and C box, what is exacerbated? It's getting better. Why is that a level 5? Why is that high risk? Hello? That isn't high risk.
No?
What?
Oh, I thought it was.
Acute or chronic illness or injury that may pose a threat to life or bodily function. Sleep apnea can kill you.
Well, I agree, but the guy is on the CPAP machine doing well. It isn't the first time walking in the door with it.
Okay.
This is a follow-up visit, maintenance. You see?
Severe respiratory distress.
But this is going back to the sleep doctor and taking the little chip to make sure that, you know, he's not stopping breathing every so often. No exacerbation, doing much better. Level 5. Okay, ready? I would disagree that that's a level 5. Would you agree? We're not even talking an ER visit.
Yeah, I don't think.
I'm on the edge on that one. I would say if it's severe enough sleep apnea, yeah, if you take him off the machine.
Yeah, but I don't think, it doesn't sound like they're taking it off.
Okay, but yet, let's talk this visit. This visit, he's coming in, no exacerbations. All he's there is to show the guy the little chip, and he puts it in the computer and he says, oh, you're not stopping breathing now anymore. 25 times an hour or whatever.
Yeah.
And there's no exacerbation. Now, it wasn't like he went to the ER in issues or anything like that. And he's a relatively healthy individual, not overweight, no hypertension, no family history of sudden coronary death, none of that. You know, I think this visit sounds like, it feels like a 2 or a 3 to me, you know. Okay, ready? Here's the next visit. A 21-year-old boy, Crohn's patient. Has had Crohn's for, well, has had issues for 2 years. At the second doctor now, this is the second doctor looking at this patient, okay? And the second doctor takes their time, sits there, looks at the colonoscopies that were done, the EGDs that were done, the allergy testing that was done, spent an awful lot of time with this patient. Never really put their hands on this patient, like exam, okay? But he billed a 99204, and I'll tell you why. Watch. That, and it gets right to your point about time. When counseling and or coordination of care dominate more than 50% of the time that a physician spends with a patient, then time may be considered the controlling factor. Let's go back to your audit tool, and I'll show you where it's written. Now, you shouldn't do this all the time, but here it is. Do you see that I put the time here? 10 minutes, 20 minutes, 30 minutes, 45 minutes, 60 minutes, 40, 25, 15, 10, and 5. If time is the controlling factor of your visit, and in this case it was, do you know why? Because the doctor had to sit there and go through this whole record of 2 years worth of stuff that was done at this other doctor. Had to look at the colonoscopies, had to look at the labs to see all the lab progressions, had to look at the EGDs that were done, had to look at all the allergy testing, and then he had to sit there and talk to this patient about what we're going to do. We're going to put you on this drug, and we're going to try this drug, and eventually if that doesn't happen, we're going to do surgery. It was all this progression. It was a lot of talking. And basically that was counseling and coordination of care, wouldn't you say? And in that instance, he did spend at least that much, because it was a new patient visit, 45 minutes. And I agreed with that one. Even though it was a 21-year-old with no issues other than this Crohn's, okay? And he never put his hands on this patient, but he billed according to time, and I agreed with it. I agreed with that, okay? And that's when you would bill according to time. When there's been an exacerbation, but as soon as you tell a doc that, all of his notes are billed according to time. And I'll tell you, that's a red flag. Don't do that. Time should be a rare thing. The key components are history, exam, and medical decision making. There are your three key components. Sometimes you can bill according to time, but you must have a blurb in your note that says, I spent 45 minutes with this patient, face to face. It's got to be face to face. I spent 45 minutes with this patient, of which 50% of it was counseling and coordination of care. And I did this, and we talked about this. Just give us a little blurb. You know, we had to manage this, and when I looked over his whole record and blah, 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 boom, you're done. You bill according to time. And you do it for instances like that, okay, where there's a lot of big record, and you got to, or there's like at your internal medicine practice, and you see Mrs. Jones for hypertension, hyperlipidemia, and diabetes. And you see her every 6 months to manage her meds. Well, since the last time you saw Mrs. Jones, a month ago, she was in the hospital. She was in the hospital but for a stroke. Well, don't you think that matters to your visit right today? And so now you're going to have to ask her about it, and you're going to have to go back in the record, and you're going to have to find out what happened at the hospital, and you're going to have to find out what they found. You see how that changes what you did today? See, that's a change since the last time that's going to affect what we do now. And you're going to have to spend time tracking down those records, getting in the Epic system and finding her medical record from that visit, and you're going to have to maybe call another doctor, and you're going to have to figure out what in the world happened. There you go, counseling and coordination time. Just document it like that, and don't do it for every note, and you're good with that, okay? That's how time is done. Real world examples. Okay, here's your other ones that we talked about. Initial hospital care, and remember, and there's only 3 levels here, okay? And it's either new or established, it doesn't matter, 3 of 3. Doesn't matter, 3 of 3. And then subsequent, so this is what you would code the first day you saw them. If you're like seeing a patient first day in hospital, this is what you would code, one of these. And then every other day after that, you code from this set right here. And all you need is 2 of 3. And basically, here it says, usually the patient is stable, recovering, or improving, 99231. Usually the patient is responding inadequate or has developed a minor complication, 99232, or a significant problem or a new complication, 99233. See? That's what you would bill every day after that, and then until the discharge day, and then you bill discharge, if you're the one that's managing their care. Common mistakes with the E&M. Usually it's review of systems. Usually review of systems makes the down code. Procedures aren't clearly documented or not documented. Suture length, multiple layers, IMD packing, splint application. Sign and date the note. Give a final diagnosis if known. Legible handwriting, that's always a biggie. Document your test results. Consults with other providers and drugs given. Why? Because all of that matters. You see how all of that matters. You see where it matters now. Documented. For injuries and poisonings, give specific details like which drugs did they overdose on or accidentally ingest. And anytime they do a drug with alcohol, automatic poisoning, automatic. All right, caution, volume, and this is important. Volume of documentation does not mean appropriateness of documentation. Increasing the documentation to achieve a higher level is fraud, okay? All right, time is money, we talked about that. Here you go. Here's your E&M coding help. Here's the thing, E&M code check. Oh, here's your Medicare MAC carrier. There it is, FCSO. There's your Medicare. They have, if you go to the evaluation and management link, online learning modules, they have guidelines, and here it is, the E&M interactive worksheet. If you ever want to do your notes, put it through the worksheet. First of all, the first thing you say is it a new patient establishment? You click that, and then you start putting everything in. All their HPI, all this, click, 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 and then at the bottom you put compute, and it'll tell you what your level should be. It's good check. It's good practice. But eventually you're all going to be able to figure this out in your head, truly, okay? Here's your coding resources. These are the, this is the AAPC. It's on this website where the benchmarking tool is. E&M benchmarking tool. In fact, if you just Google it, E&M benchmarking tool, and you put cardiology or dermatology or whatever, and you push calculate, it'll tell you where your range should be, your bell curve, for both new patients and established, based on 2010 data across the country. For Medicare patients now, for Medicare. American Health, and that's a HEMA, that's hospital side. And they are big into I-10. Big into I-10. Okay, here, I gave you some apps, because you guys are so, so much more technologically savvy than people like I am. So here we go. So I gave you some apps for both I-10 and I-9. And now remember, it's not a 1-for-1 a lot of times between I-9 and I-10. Usually, sometimes it is. Sometimes there's a 1-for-1. Sometimes there's a 1 to 20 I-10 codes. Sometimes there's 1 to a lot of I-10 codes. So if people say, well, I can get 1 to 1, not all the time. That's why we're going to I-10, because there's so much more specificity. All right. Oh, and here you go. Like me, I don't know, is it this one? Oh, there we go. Follow me on Facebook. If you follow me on Facebook, I give coding tips. Like, well, I try to do it every week, but sometimes it doesn't happen. But anything that happens with I-10, I'll be right on it, because I'm reading a bunch of blogs and I'm on that stuff. Obviously, it's got to affect me. So if you follow me on Facebook, you'll get some of my coding tips that I put out there. And then when you get into the field, if you see issues, if you just don't understand something, if your doctor doesn't understand something, or something's going on in your office, that's when you call me, because I know we've got coders, we've got billers, we've got a bunch of stuff we can help. Okay, because that's where you call somebody, that you would trust. All right? Okay. Wow, early. Isn't it great?
Yeah, it's fabulous. Yeah.